The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
This is Tony Urbanek, and I am here to present the next installment of our podcast entitled Demystifying TMD. Today's presentation is going to focus on a very important part of enlightening patients about their problem. I've talked before, I am sure, about the different steps of a consultation. The last podcast presented the very short but concise and extremely important examination itself, 2-minute exam. This presentation is going to talk about what comes after, and what comes after is a very meaty part of the consultation. And again, I want to emphasize, you doctors can do your consultation presentation any way you'd like, but what I have to say, present, is based on at least 8 years of focus on patients with temporomandibular joint problem, enlightening them on what they need to know so that they understand the problem and they can accept treatment, and that they do best with following instructions about how to treat their own problem using our device, a device, and protocol. Because obviously the device is just a tool. You have to know how to use it, both from the doctor's point of view and the patient's point of view. Now, from the patient's point of view, I'm sure you all know, when you discuss with your patients why it's important to have the bridge, or why it's important to do periodontal treatment, or why it's important to take out their wisdom teeth, what you're doing is building knowledge, or hopefully what you know you're doing is building knowledge about the problem with the patient so that they can understand why this service needs to be done for their benefit. Nothing wrong with any of that. In this case, we're dealing with a problem that, for the most part, everybody knows that nothing works. Now, I say that with great certainty. I say that with all of my knowledge that I've accumulated over talking to patients about this for a long, long time, one way or another, through their own experience or what they read on the internet or wherever it comes from. The patients, if they have any experience with prior treatment, are very frustrated with it. And the doctors themselves, I have these conversations every day. I just had a couple conversations this weekend at a very large meeting of oral and maxillofacial surgeons in the state of Tennessee. And you know, when I talk to my colleagues, who I know very well personally, about TMD and what I've discovered and how we treat it, very frequently, not all, but very frequently is, you know, Tony, I really admire you for what you've found out and what you do and what you've done, but I don't like to deal with these patients. And I hear that all the time, unfortunately. And it's to the detriment of the patients, for sure, because they're not getting treatment, and it's the detriment of the doctor in the practice who does not get to experience a success or multiple successes on this problem. So that's just a preamble of what I have to say. And so this next part is actually, once the diagnosis is made, once you take your symptoms, which are red flags, and you have a list of symptoms to make you suspicious, this may be TMD. And then you do your exam, which nails it down. The joints are inflamed. Oh, it is TMD. The joints are inflamed. It hurts. You made your diagnosis. Now what do you do? Well, now what you want to do is you want to educate and inform the patient to build a relationship, build understanding, take down the skepticism, build trust. Because there are two categories. I find there, well, maybe more categories, but there are two definite categories of patients that I see regarding this this issue with the diagnosis, and that is those who mistrust that anybody knows anything about this. And then there's the smaller category, but I see it. I see it very visually. There's a category of patients who just mistrust doctors. I know you've seen that if you pay attention, if you're aware. Unfortunately, and I won't go into why that is too deeply. I think some of it has been self-induced. Some of it has been induced by other things that are not appropriate. But there is a category of patient who just across the board distrust doctors, but they have a problem. They're trying to get it fixed. Nobody else seems to know what to do. All right, so that part of the consultation is I'm going to use the same patient I used last time. And by the way, the patients that we use on these videos have given us written approval, HIPAA compliant, to use their videos for information that can be used for doctor instruction and purposes as we're doing right now. So we have full compliance, written compliance, and approval from the patients to do this. And again, I know I have at least over 200 videos of patient consultations for just this person and purpose. And this patient is just typical. There's nothing atypical about this patient that I chose at all. Very typical. So I'm going to, after I've finished discussing what you're about to see briefly, I'm just going to show that portion of the consultation that starts from the point that I made the diagnosis after the examination to the point where I tell the patient what can be done with the device and protocol and how much it's going to cost. I'm going to exclude that. I'm going to exclude that from the video, but the last part is not telling the patient what can be done. It's telling the patient how we take impressions, which we now do most of the time. We do with scanning, and then what the fee is, and send them off to the front office to discuss fee payment. All right, so what are you going to look at here? What I have honed over the years is a very brief, concise way to get the patient all the information they need, decrease skepticism, build trust, and make sure that they understand their own problem. Because I have never had one of my patients, 5,000 plus patients, who have ever had anybody sit down with them and explain what's going on that creates all these symptoms of headache, earache, jaw pain, neck pain, tinnitus, subjective hearing problems, vertigo, upper shoulder and arm pain, arm, hand, finger tingling, and numbness and locking, and a few others that we'll discuss some other time. Less frequent, and in any case. So how do you do this? So what you're doing is developing understanding between the doctor and the patient. When you actually develop understanding, that will decrease the skepticism. They will increase the desire for treatment, and most importantly, increase trust between you and the patient, and the trust between the patient and the doctor, because trust goes both ways. You have to trust your patient to actually do the protocol, to come on board, get treatment, follow through, and get treatment. So the first part of this is just, once you start talking, I talk about just a description of the anatomy, the ball, the socket, and the cushion. I call it a cushion rather than disc or meniscus. I don't think I need to remind you, always use small words with the patient. Don't use big words with the patient. You'll lose them right then. Just use really words that you know that they're going to understand. So I always use the word cushion rather than disc in between the ball and the socket. I like to literally show them. Here's the ball and the socket, and in between is a little cushion about the size of a nickel, thick as a nickel, round as a nickel, sits as a cushion in between the ball and the socket. That is the area that we're talking about. And then we cover the causes of damage to the joint itself. There are only 3 causes, as I covered before, but they're all traumatic. All the causes of damage to the joint are traumatic. There's bruxism, which is chronic trauma to the joint. There is acute trauma to the joint, very frequently seen in automobile accidents and whiplash injuries, very common in whiplash. And then the third is functional malocclusion, which is nothing more than another type of chronic trauma, functional malocclusions of one kind or another. We cover that, and then description of how these symptoms that they have, sometimes I'll go through their symptoms that they gave me, but their symptom list bounces around. It's not always the same symptom. It can be any of those symptoms on their list. And very importantly, and I learned this from the patients, I didn't learn this out of textbooks, but the patients kept on saying after time how their symptoms cycle. They go up and they go down, and they go up and they go down, always getting worse. That is 100% of the time the history that a patient with TMD will give you. Their symptoms are never, their symptoms are always come and go, whether they be painful symptoms or non-painful symptoms. Non-painful symptoms like categorized as tinnitus, subjective hearing problems, and vertigo. And then when you describe the patient's symptoms and how you know that they always cycle and always getting worse, and in some patients, they get worse and worse, and then they don't go down. They're just constant at a high degree of discomfort, of pain, dysfunction. And they always shake their head. And a lot of them kind of their eyes open and they go, how did you know? That's how I know that is because I've talked to thousands of people. And I listened, not talked, listened to thousands of patients telling their stories, which goes back to step 1 of the consultation. Always sit down. Number 1, sit down and listen to the patient's story. You will learn. You will learn more than you will teach, especially at the beginning. When you listen to the patient's symptoms, and they will tell you things that will coincide with what I'm telling you. And the lights will go off on both sides, the patient's understanding and your understanding. The more you do it, the more you understand. And then also we go then through the mechanism as how the device unloads the joint, and the device, the practical device, practical nature of the device, which is so simple. I mean, you can unload the device with your finger between your teeth. In fact, years and years ago, when I was first getting into this, and I was first coning my presentations on this, and sometimes I had a little more time to talk to the patients. And I remember telling one lady about the fact of how I learned about this, and patients told me that if they take a finger or their tongue or a pencil and gently put it between their front teeth, it feels better. After I went through my entire presentation, I said, do you have any questions? And the woman looked at me in all sincerity, and she said, do you mean that if I hold a pencil between my front teeth, it will make all these symptoms go away? And I said, well, yes, ma'am, it will, if you can figure out a way to hold that pencil between your teeth for a minimum of 2 months. I don't know what she was thinking. I don't know whether, I don't remember. I remember thinking at the time, I wonder what she's thinking of me, but I just tell people what I know. I don't try to figure them out. That's a good suggestion for everybody. Don't try to figure out your patients. Just tell them what you know, try to help them, and let the cards fall where they may. Very interesting. But the point I'm trying to make is that a device that separates the back teeth does nothing more, nothing less than unload the temporomandibular joint. That's how it works. And that's why I explain it to the patient. All we're doing is unloading the temporomandibular joint, just like a set of crutches would unload your knee. I use that description fairly often. That resonates with the patient. They understand it. They don't understand much about inflammation. For most of them, they do know the word. You can use that word a lot because they do understand the general nature of inflammation. Certainly what they don't know is what you now know, is how inflammation directly causes all these problems. But they do understand the concept: if you can make the inflammation go away, the symptoms go away. And I always make sure that they understand that all we're doing here is unloading the joint long enough, and that their part of this is they have to follow the protocol to unload it long enough using a device that they can keep in their mouth 24/7 for at least 2 months, 24/7, except when they're eating. So we go through that part of it. And as you'll see on the video, I'm pretty rote. Frankly, I'm very rote in my steps and in the presentation. I go through it pretty rapidly, maybe sometimes too rapidly, depending on how pressed I am for time and how many patients I have waiting. But I do this for your benefit. I show this to your benefit to show you how simple it is to explain it to a patient. You don't need to get complicated. You need to be simple with patients. Use simple terms, use simple mechanisms, use simple concepts that the patient can understand. And especially when they then can see that you understand their problem. And that's what this portion is all about: showing the patient that you understand the problem, you understand their problem, and then the trust goes up significantly, the skepticism comes down significantly, and they will say, yeah, I want to do this. And frankly, once you get to that point, I mean, they all want to do it. They all want to get rid of their symptoms. All right, I guess that's enough of the preamble about this. The other thing was the expectations. I always go over what they can expect once they use the device, and that is based on easily by my experience. And as you gain experience, if you do this, as you gain experience, you will be more and more certain about what you're about ready to tell the patient, and that is painful symptoms come down very fast. Headache, earache, jaw pain, neck pain, shoulder pain. Within the first week or so, you will see significant decrease of your painful symptoms. I always remind them their symptoms over a period of time, whether it be 2 years or 40 years, did not go up smoothly. Their symptoms went up like this. When they go down, they do not go down smoothly. They go down like this. I always make sure they understand that at some point in the treatment. May not be in the consultation part, but I always make sure they understand that. But painful symptoms come down fairly rapidly. Within the first week or so, patients follow the protocol, keep it in 24/7. They will come back at 3 weeks and they will say, on average, the average number after 3,000+ people is 70% of my symptoms are gone in the first 3 weeks, painful symptoms. The other symptoms that I call middle road symptoms are tinnitus, subjective hearing problems, and vertigo. Again, the description of why that is and how that is anatomically physiology is going to be at a later podcast. I have a lot to say about that as an anatomist and cell biologist, along with my medical degree, dental degree. I figured out how that happens in the inner ear. So those symptoms are definitely, we all know they're related. We all see that, we all hear about it from the patient: tinnitus, vertigo, and subjective hearing problems, like they're talking in a bell, or they're in an airplane, or that their ear is full of water and they can't make it pop. Those 3 symptoms go away slowly. Tinnitus is the symptom that hangs on the longest overall, and sometimes will last many months, 6 months, 8 months, even longer, until it diminishes. That's a different podcast that I have a lot to say about it with my experience. But I can prove it that tinnitus, you use this device in proper way long enough, and tinnitus will diminish, which we need to really get out as a dental profession, get out in the middle of the ENT profession and our medical colleagues, and make sure that they begin to understand that, because they do not have an answer for tinnitus and vertigo and subjective hearing problems. Okay, so we're going to show the video, and then I'm going to come back and just make a few closing remarks. From your jaw joints. Once we've established a diagnosis, half of my job is to explain to the patient what's going on so you understand it. Half my job is to make the symptoms go away. Okay. Both of them are pretty easy to do, but the first part's almost as important as the second part. So this is what you need to know and understand about the problem. Everybody has two jaw joints, ball and a socket. In between the ball and the socket is a little cushion made out of cartilage. It's about the size of a nickel. It's about as round as a nickel, thick as a nickel, sits as a cushion in between the ball and the socket. That cushion is the source of 100% of the symptoms that people come in with jaw joint problems. That little cushion can get damaged due to one of three causes. There are only three causes. You have to have at least one of them present to damage the cushion. The causes are clenching or grinding the teeth over a long period of time, which you definitely do. Just by looking at the wear on your teeth, I can tell you do that. Trauma to the face and the jaws, especially something having to do with a whiplash injury. Okay. And the third is jaw growth problems. Big jaws, little jaws, open bites. You don't have a jaw growth problem. You do give me a history of trauma at age 13, right about the time this all started, and you definitely clench or grind your teeth. So out of the three potential causes, you have two of them. What they all have in common is they all damage the cushion. When the cushion is damaged, it will not heal, ever. And the reason it won't heal, it has a very poor blood supply, almost none. So rather than go on and heal like normal tissue does, it surrounds itself with inflammation. Inflammation is the body's response to damage, any kind of damage. And inflammation has a cycle to it, meaning it comes and it goes. When the inflammation goes up, it brings on symptoms. What symptoms? Whichever ones you've accumulated over time. You don't have to have all the symptoms, and the symptoms will definitely bounce around between and among the symptoms, depending on patient and circumstance. But the symptoms of jaw joint problems are frequent or recurring headache, earache, jaw pain, neck pain, ringing in the ears, feeling of fullness in the ears, vertigo, dizziness, shoulder pain, arm, hand, finger tingling and numbness, and locking.
Oh, wow.
And you have each and every one of those. Then the body itself will spot that inflammation, and with or without the help of Motrin, Tylenol, aspirin, or whatever else you've been taking for the pain, it will drive the inflammation down for a while, and it will feel better for a while. Then the inflammation will creep back, and it'll hurt again, only this time it won't hurt more, stay longer. Go away for a while, come back, hurt more, stay longer. Go away for a while, come back, hurt more, stay longer. Always cycling, always getting worse. Is that real to you?
Yes, sir.
That is the natural history on 100% of people with jaw joint problems, 100%. This is a very common problem. This is not unique to you. 45% of females have temporomandibular joint symptoms of one kind or another between ages 13 and 75. It is seen almost exclusively in females, 95% females, 5% males, and almost exclusively in females who are either highly motivated or highly stressed. Raise your right hand if that fits you.
That's definitely me. One tense person, Dr. Stewart told me.
So that's what's going on, Andrea.
Okay.
So what do you do about it? Patients who come to see me, and I'm the jaw joint guy, have three options. First option is a silly option. I give it to everybody. Some people choose it because it's a real option. Do nothing if you want to hang on to your symptoms. The third option does not apply to you, which is surgery. You're not a surgical problem. Okay. I would not recommend or do surgery for you for many reasons, but the biggest reason is you don't need it. I can get you comfortable, keep you comfortable, make all of those symptoms go away using this device and a little common sense. Okay. This is a tool that has to be used correctly, but it just works super well. As soon as I pull it out, we got to talk about what it isn't, because everybody thinks they know what it is. It's not a retainer from the orthodontist, although it looks like that. It does fit in the mouth behind the upper front teeth, but it doesn't do anything inside the mouth. Nothing zero zip. Secondly, and most important, this has nothing to do with stopping you from clenching or grinding your teeth. We don't know why people clench or grind. We don't understand the mechanism. There is no on and off switch, and you have no control over it, never will.
The only thing we know about clenching or grinding is related to stress. The more stress, the more people tend to clench or grind, and we do not even have a good definition of stress. So that's all a long dirt road with a dead end. Don't bother going down it, you won't find any answers, but none of that has anything to do with this or how it works. So what is it and how does it work? My patients years ago gave me the key as to how to make this thing. As I said, it fits in the roof of the mouth behind the upper front teeth, and when used correctly, it does only one thing. It takes the load off the jaw joints. When the load comes off the jaw joints, the inflammation dies down. When I pushed on your joints, the only thing I found out was that they hurt. They hurt because the joints are inflamed. That's the definition of jaw joint problems. So when this is in your mouth, it decreases the inflammation. When the inflammation goes away, all the symptoms go away. Now you have to use this correctly if you're going to get one. You got to start out 24/7 for the first 2 months, except when you chew. You can drink with it in your mouth. Coffee, tea, soup, hot fluids are fine, but when you go to eat, you got to take it out. After you eat, you brush your teeth. You brush your device with toothbrush, toothpaste only. Put it back in. Within the first week or so, you will note significant decrease in your painful symptoms. Ringing, fullness, dizziness, those 3 symptoms work through a separate mechanism. They go away slowly. Sometimes it takes several months for those to calm down, but the painful symptoms will calm down very fast. Now the way this works, the mechanism was quite simple. This was the breakthrough. When this is in your mouth, only your lower front teeth touch this little pad right here, and the back teeth are held slightly apart. That's why it works, because we now know it's through the loads on the back teeth only that you load these joints. If you can't get your back teeth together, no matter how much you clench or grind, you can't load the joint. When the load comes off, the inflammation goes down. When the inflammation goes down, the symptoms go away. Then I'll follow you along once we get you into, once we get through the first 2 months 24/7, usually around 2 months, I'll say now we're ready to go to nighttime only. You will then be in this nighttime only the rest of your life. You put it in at night, take it out in the morning, put it in at night, take it out in the morning. I'll follow you along a little beyond that once we get you into nighttime to make sure you don't backslide and you know how to monitor the use of it yourself. And after 3 or 4 appointments here over a period of about 4 or 5 months, I will say, Andrea, come on back if you ever have any more trouble. The only people who come back are the people who lose this device or break it, because if you quit using it, your symptoms are going to come back. The only people who lose it or break it are people who do not keep it in the case we give you. It is safe when it's in your mouth. It's safe when it's in the case. Anywhere else for a split second, not safe. So like I said, if you use it correctly, you'll get pain relief fairly quickly. Within the first week or so, you will see those painful symptoms coming down. Ringing, fullness, dizziness go away slowly.
Okay. Can I ask you a question?
Sure.
So what causes I know it's all connected, but what causes like the ringing and the fullness feeling from your jaw?
It all is connected. It is all, as again, it's all caused by the common denominator is inflammation. Now, inflammation causes the muscles to get a signal to get tight. And when the muscles get tight, it hurts in different areas. But the ringing, fullness, dizziness, the mechanisms for ringing and your vestibular mechanism for keeping you upright so you're not dizzy are that far away from this joint. And when this joint becomes inflamed, it spills over into the inner ear, and that's when people complain of ringing, fullness, and dizziness.
Okay, that makes sense. I know this.
Yeah.
Yeah.
Yes, that's exactly what it is.
I mean, it's crazy that all these symptoms that I've been going to so many doctors for are all caused from my jaw, because, I mean, they thought for sure I had, carpal tunnel, and
I understand.
it happened all suddenly, but I was highly stressed, and that didn't make sense to me.
Yeah.
So
I understand. We see a lot of it. A lot of doctors are not aware of jaw joint problems. Dr. Stewart is, by the way, very well. I know Dr. Stewart. He knows all about it. That's why he was able to pick this up pretty quick.
Yeah, I mean,
All right. So you've taken the time to watch the video. I didn't time it exactly yet, but I'm guessing it's probably that video. The part of the consultation ran about 5 minutes, something like that. And I just want to emphasize how important it is for you to educate the patients, whether or not they get your service or not, get the device. is not the point. If the patient comes in to see you with the problem, you owe it to the patient to educate them about what you know. I do. I feel, I mean, sometimes I'm into the consultation for a few minutes, and I pretty much know that this particular patient, because of economic reasons or because of who knows why, this patient's not going to go forward with treatment. And that doesn't slow me down. I make sure that I honor the patient and give them all the information that they came to get and see me and pay me for, that they deserve. And that is why this part of the consultation is, as far as I'm concerned, the most important part. Obviously, you need to nail down a diagnosis, be certain of your diagnosis, et cetera. That is super, super important. But in my opinion, getting the patient to understand what their own problem is, whether or not they go through with the service or not, is extremely important. I think that's what I really wanted to get across to you after you watch this part of the video. So, as always, doctors, ladies and gentlemen, I appreciate your attention. I appreciate your interest in this podcast, TMD Demystified. I'd like all of you to become TMD warriors, like I am. I am on a mission. I am on a mission personally. My company is on a mission to have as many patients with this problem receive proper treatment. Which brings to mind the study that we've just finished up, independent study, and coming through and done through Middle Tennessee State University based on our 3,000 successfully treated patients. I'll have a lot of time to talk about that later. I don't want to keep you any further on this. But anyone who would like to learn more about what I've discovered, how I've used it, what we do, how we really solve this problem, can contact our Director of Marketing Education, Naomi. Through her, you have access to me. I think that we will also put up on my personal company email address. Please email me. I look forward to comments, questions, and if you'd like to join our network of providers, that's easy enough to do. Take the course on how to use the device and all the things that you need to know about how to use it. Enough for today. Hope you have a successful week. I look forward to talking with you next week on the next installment of TMD Demystified. I'm Tony Urbanek. Bye.